Lewis's Medical Surgical Nursing, 11th edition, Chapter 58, Chronic Neurologic Problems. This narration is going to be abridged as it reflects a focused curriculum at my specific school. Headaches. Headache is the most common type of pain that people have. Most people have functional headaches such as migraine or tension type headaches. Others have organic headaches caused by intracranial or extracranial disease. Headaches tend to occur more often in women than in men. Pain-sensitive structures in the head include venous sinuses, dura, and cranial blood vessels. In addition, there are three divisions of the trigeminal nerve: cranial nerve 5, facial nerve, cranial nerve 7, glossopharyngeal nerve, cranial nerve 9, vagus nerve, cranial nerve 10, and first 3 cervical nerves. Because these nerves have both motor and sensory functions, increased pain intensity and symptoms can occur when a person moves. Headaches are classified as primary or secondary headache. Primary headache include tension type, migraine, and cluster headaches. Primary headaches are not caused by a disease or another medical condition. Type of primary headache is determined using the International Headache Society guidelines based on characteristics of the headache. Secondary headaches are caused by another condition or disorder such as sinus infection, neck injury, and brain tumor. Patient may have more than one type of headache. The history and neurologic examination are diagnostic keys to determine the type of headache. The examination of a person with a headache is often normal. Unexplained abnormal findings require further diagnostic studies to identify the underlying cause. Tension type headache. TTH, also called stress headache, is the most common type of headache. This type of headache is characterized by its bilateral location and pressing or tightening quality. TTH is usually a mild or moderate intensity. It can last from minutes to days. TTHs are divided by frequency into episodic or chronic. Chronic TTH can become a serious problem that leads to decreased quality of life and severe disability. Etiology and pathophysiology. We do not know the cause of TTH. It may have a neurobiologic basis similar to migraine headaches. For some, episodic headaches evolve into chronic headaches. Increased frequency, though, does not necessarily increase headache intensity. Headaches may occur intermittently for weeks, months, or even years. Clinical manifestations. Patients often have a bilateral frontal occipital headache described as a constant dull pressure or a band-like headache associated with neck pain. There may be increased tone in the cervical and neck muscles. The headache may involve sensitivity to light, photophobia, or sound, phonophobia, but not nausea or vomiting. There are no premonitory symptoms, warning symptoms of impending headache. Physical activity does not worsen symptoms. Many patients have a combination of migraine headache and TTH, with features of both occurring together. Patients with migraine headaches may have TTH between migraine attacks. Diagnostic studies. Careful history taking may be the most useful tool for diagnosing TTH. If TTH is present during physical examination, increased resistance to passive movement of the head and tenderness of the head and neck may be seen. Electromyography, EMG, may show sustained contraction of neck, scalp, or facial muscles. However, the patient may not have increased muscle tension with an EMG, even when it is done during a headache. Imaging is ordered when symptoms raise concern about a possible pathologic cause. Migraine headache. Migraine headache is a recurring headache characterized by unilateral throbbing pain. Migraines are most common between the ages of 25 and 55. 12% of the population has migraines. Many people who have migraines have a family history of migraines. Other risk factors include age, female gender, obesity, low level of education, depression, and stressful life events. Overuse of medications for acute migraine or ineffective acute treatment can contribute to chronic migraine headache. The IHS subdivides migraines into categories. Migraine without aura, formerly called common migraine, is the most common type. Migraine with aura, formerly called classic migraine, occurs in 25 to 30% of migraine headache episodes. Etiology and pathophysiology. Although there are many theories about the cause of migraine headaches, we do not know the exact cause. Current theories suggest a complex series of neurovascular events starts the headache. People who have migraines have a state of neuron hyperexcitability in the cerebral cortex, especially in the occipital cortex. Genetics appear to play a role. Risk for migraine headache increases 50 to 75% if even one parent has a history of migraine. Migraine is associated with seizure disorder, ischemic stroke, asthma, depression, anxiety, myocardial infarction, Raynaud's syndrome, and irritable bowel syndrome. In many cases, migraine headaches have no known precipitating events. For some patients, specific factors may trigger a headache. Triggers for migraine headaches include bright lights, sound, hormone fluctuations, certain smells, poor sleep, or high stress. Common food triggers include chocolate, cheese, oranges, tomatoes, onions, MSG, aspartame, and alcohol, especially red wine. Clinical manifestations. Premonitory symptoms and an aura may precede the headache phase by several hours or days. Premonitory symptoms occur because the onset of aura or headache. It may include sensory experiences, e.g. photophobia, phonophobia, mood, sleep, or cognitive changes, e.g. poor concentration, irritability, fatigue, and homeostatic changes, e.g. thirst and cravings, change in bowel habits. An aura is a complex of neurologic symptoms that occur before a headache for some patients. Visual symptoms such as bright lights, scotomas, patchy blindness, visual distortions, or zigzag lines are the most common type of aura. They occur in over 90% of patients in at least some attacks. Sensory, voices or sounds that do not exist, strange smells, and or motor phenomena, weakness, paralysis, feeling that limbs are moving, may be part of an aura. A migraine headache may last 4 to 72 hours. Patients often describe the headache as a steady, throbbing pain that is synchronous with the pulse. Although the headache is usually unilateral, it may switch to the opposite side in another episode. During the headache, patients may try to avoid noise, light, odors, people, and problems. Diagnostic studies. Diagnosis of migraine headache is usually based on the patient history. Neurologic and other diagnostic examinations are often normal. No specific labs or radiologic tests can diagnose migraine. Neuroimaging techniques, e.g. head CT, with or without contrast, MRI, are not part of the routine evaluation of headache unless the neuroexam is abnormal. If atypical features are present, further testing is done to rule out a secondary headache. Cluster headache. Cluster headache is the most severe form of primary headache. It's classified as a trigeminal autonomic cephalalgia, TAC. This reflects its effect on the trigeminal nerve, CN5, and associated autonomic symptoms, e.g. runny or stuffy nose. Repeated headaches occur in clusters generally at the same time of day or night. Age at onset is typically 20 to 50 years. They can start at any age. They affect men more than women. They occur more often in persons who smoke. Less than 1% of people in the United States have cluster headache. Etiology and pathophysiology. Neither the cause nor how cluster headache occurs is fully known. The patterns of cluster headache suggest dysfunction of the hypothalamus, Many attacks occur at night, waking the person 1 to 2 hours after falling asleep. This may mean there is a circadian rhythm problem. Alcohol is a dietary trigger. Pain often starts within an hour of a drink. Strong odors, e.g., gasoline and paint fumes, can trigger cluster headache. Clinical manifestations. Patients with cluster headache have severe intense pain lasting from a few minutes to 3 hours. In contrast to the pulsating pain of migraine headache, pain of cluster headache is sharp and stabbing. Pain is usually around the eye, radiating to the temple, forehead, cheek, nose, or gums. Other manifestations may include swelling around the eye, lacrimation, facial flushing or pallor, nasal congestion, and miosis, pupil constriction. Most patients have at least 3 of these symptoms. During the headache, the patient may be agitated and restless, unable to sit still or relax. Cluster headaches can occur every other day and as often as 8 times a day. Cluster typically lasts 2 weeks to 3 months, and then the patient goes into remission for months to years. Typically 2 cluster periods a year may be separated by months without symptoms. Because cluster periods often occur seasonally, headaches may be mistaken for symptoms of allergies. A small number of patients, 10 to 15%, have chronic headaches without remission. Diagnostic studies. The diagnosis of cluster headache is based on the patient history according to IHS criteria. Asking patients to keep a headache diary can be useful. CT scan, MRI, or magnetic resonance angiography (MRA) may rule out an aneurysm, tumor, or infection. A lumbar puncture may rule out other disorders that may cause similar symptoms. Other types of headaches. Other types of headaches can occur. A headache may be the first symptom of a more serious illness. Headache can accompany subarachnoid hemorrhage, brain tumors, intracranial masses, vascular abnormalities, trigeminal neuralgia, tic douloureux, diseases of the eyes, nose, and teeth, and systemic illness, e.g. infection, carbon monoxide poisoning, altitude sickness, polycythemia vera. Because of the varied causes of headache, thorough clinical evaluation is important. It should include assessment of personality, life adjustment, environment, and living situation, as well as comprehensive evaluation of neurologic and physical condition. Interprofessional care for headaches. If no systemic disease is the cause, the type of headache guides therapy. Table 58.2 outlines the general assessment of a patient with headaches to rule out any intracranial or extracranial disease. Cognitive behavioral therapy and relaxation therapy used alone or in conjunction with drug therapy may help some patients. Biofeedback involves the use of physiologic monitoring equipment that gives the patient information about muscle tension and peripheral blood flow, e.g. skin temperature of the fingers. The patient is trained to relax the muscles and raise the finger temperature. Reinforcement occurs when the patient makes these changes. Acupuncture, acupressure, and hypnosis are options for some patients. Drug therapy. Tension type headache. Drug therapy for TTH usually involves aspirin, acetaminophen, Tylenol, or NSAIDs. Used alone or in combination with caffeine, a sedative, or a muscle relaxant. Treatment is often disappointing. These analgesics may only be partly effective even with use of the maximum dose. Stronger analgesics provide no additional benefit. Some analgesics may make the headache worse. Many of these drugs have serious side effects. Caution the patient about the long-term use of aspirin or aspirin-containing drugs because they can cause GI bleeding and coagulation abnormalities in some patients. Drugs containing acetaminophen can cause kidney damage, chronic use, and liver damage when taken in large doses or when combined with alcohol. To decrease the recurrence of TTH, many patients take an antidepressant. Common drugs include tricyclics, e.g. amitriptyline, nortriptyline, Mirtazapine Remeron, a non-adrenergic serotonergic antidepressant, and venlafaxine Effexor. Anti-seizure drugs such as Topamax or Divalproex, Depakote also may be used. Migraine headache. The aim of drug treatment of an acute migraine is stopping or decreasing the symptoms. Many people with mild or moderate migraine headache can get relief with NSAIDs, aspirin, or caffeine-containing analgesics. For moderate to severe headaches, triptans are the first line of therapy. Triptans, e.g. sumatriptan, Imitrex, affect selected serotonin receptors. They reduce neurogenic inflammation of cerebral blood vessels and cause vasoconstriction. Some patients respond better to a certain triptan than to others. Triptans are most effective when taken at the start of a migraine headache or during the aura. Sumatriptan is available in several dosage forms and delivery systems: oral, subcutaneous, nasal spray, transdermal. It's also the only ultra-fast-acting triptan. Combination of oral sumatriptan and naproxen sodium, Trexamet, is more effective for symptom relief than either medication alone. Because triptans cause vasoconstriction, they may not be appropriate for people with heart disease, hypertension, high cholesterol, or history of stroke. When triptans are contraindicated or ineffective, other drugs can be used. Preventive treatment is important in managing migraine headache. The decision to start preventative treatment is made based on frequency, severity, and disability related to headaches. Several different classes of medications are used. Topiramate, an anti-seizure drug, may be taken daily for migraine prevention. Common side effects include hypoglycemia, paresthesia, weight loss, and cognitive changes. Usually these side effects are mild to moderate and transient. Topiramate must be taken for 2 to 3 months to determine its effectiveness. Not all patients become pain-free. HCPs must offer thorough teaching to promote patient adherence. Extended release forms promote adherence with fewer cognitive effects and higher rate of effectiveness. Beta blockers have been effective in migraine prevention. Commonly prescribed agents include toprolol lopressor and propranolol indorol. Propranolol is similar to amitriptyline in its efficacy. Atenolol, Tenormin, and Nadolol, Corgard, are other options for migraine prevention. Botulinum toxin A, Botox, may be effective prophylactic treatment for adults who have chronic migraines at least 15 days each month or migraines do not respond to other medications. Botox is given by multiple injections around the head and neck into the pain fibers involved in headaches. Maximum benefit may not be seen for up to 6 months. During this time, the patient should continue their regular medications. Injections are usually given every 3 months. The most common reactions are neck pain and headache. That's right, headache. Slight risk exists for the toxin to migrate from the injection site to other areas of the face and neck, causing swallowing and breathing difficulties. Teach the patient to seek immediate medical attention if this occurs. Cluster headaches. Triptans are the standard of treatment for occasional cluster headache. Nasal administration or subcutaneous injection is appropriate. However, as discussed earlier, they are contraindicated for patients with vascular risk factors due to their vasoconstrictive effects. High flow 100% O2 by non-rebreather mask is well tolerated, safe, and effective as an alternative treatment. O2 delivered at a rate of 6 to 8 liters per minute for 10 minutes may relieve headache by causing vasoconstriction and increasing synthesis of serotonin in the central nervous system. Treatment can be repeated after a 5-minute rest. A drawback of this treatment is that the patient must have continuous access to the O2 supply. Those with chronic cluster headache often need preventative treatment. High dose verapamil is the first choice drug. It is typically given at double or more dose used for other disorders. Because of its effects on cardiac conduction, verapamil should be started only after careful consideration of the risks. Careful monitoring is needed during treatment. An electrocardiogram (ECG) should be done with every dose increase and every 6 months during treatment for patient safety. Other drug options may include lithium, ergotamine, anti-seizure drugs, e.g. topiramate and melatonin. Options for patients with refractory cluster headaches include invasive nerve blocks, deep brain stimulation, and ablative neurosurgical procedures, e.g. percutaneous radiofrequency. Other headaches. Patients with frequent headaches may overuse analgesics or other medications used for headache treatment. Medication overuse headache, MOH, is the term used to describe a new type of headache or marked worsening of a pre-existing headache condition. Drugs known to cause this problem are acetaminophen, aspirin, NSAIDs, triptans, ergotamine, and opioids. Headache often occurs daily, is present on awakening. Patients may have nausea, restlessness, weakness, lack of energy, decreased memory, difficulty concentrating, depression, and irritability. Treatment involves abrupt withdrawal of the offending drug, except for opioids, which must be tapered, and using alternative drugs such as amitriptyline. Some people have chronic headaches that are difficult to treat. IV medication administration with novel therapies such as ketamine and lidocaine and neurostimulation are emerging as options. Nursing management, headaches, nursing assessment. The history is key and focused on specific details of the headaches. These include location and type of pain, onset, frequency, duration, relation to events, emotional, psychologic, physical, and time of day of the occurrence. Ask about illness, surgery, trauma, allergies, family history, and response to medication. A thorough history may suggest headache is due to other drug therapies or a condition other than the headache. For example, estrogen withdrawal headache is possible during the drug-free interval of an oral contraceptive. Ask the patient to keep a diary of headaches with specific details. This record can help identify the type of headache and precipitating event. If there is a history of migraine, TTH, or cluster headache, ask the patient if the character, intensity, or location of the headache has changed. The answer may be an important clue about the cause of the headache. Nursing diagnoses. Nursing diagnoses for the patient with headaches may include acute pain, lack of knowledge. Planning. The overall goals are that the patient with headaches will 1. Have reduced or no pain, 2. Understand triggering events and treatments, 3. Use positive coping strategies to deal with pain, and 4. Have increased quality of life and decreased disability. Nursing implementation. An inability to cope with daily stresses can cause headaches. Less effective treatment may involve helping the patient examine the daily routine, recognize stressful situations, and develop effective coping strategies. Help the patient identify precipitating factors and develop ways to avoid or minimize them. Encourage daily exercise, relaxation periods, and socialization as ways to decrease headaches. Suggest relaxation medication and other ways to address headache pain. Teach the patient about drugs prescribed for preventative and symptomatic treatment of headache. Patients should be able to describe the purpose, action, dosage, and side effects of the drugs. To prevent accidental overdose, urge the patient to make a written note of each dose of drug or headache remedy. In addition to using analgesics and analgesic combinations to relieve headache, encourage the patient with migraines to seek a quiet, dimly lit environment. Massage and moist hot packs to the neck and head can help a patient with TTH. Provide dietary counseling for the patient with headaches triggered by food. Encourage the patient to eliminate foods that may provoke headaches. Active challenge and provocative testing designed specifically to provoke symptoms with suspect foods may help determine specific causative agents. However, teach the patient that food triggers may change over time. Teach patients to avoid smoking and exposure to triggers such as strong perfumes and gasoline fumes. Cluster headaches may occur at high altitudes with low O2 levels during air travel. Ergotamine taken before the plane takes off may decrease this risk. Evaluation. Expected outcomes are that the patient with headaches will report satisfaction with pain management, use drugs and non-drug measures appropriately to manage pain. Chronic neurologic disorders. Seizure disorder, also known as epilepsy, is a group of neurologic diseases marked by recurring seizures. It is the fourth most common neurologic disorder. Only migraine, stroke, and Alzheimer's disease occur more often. About 3.4 million Americans have seizure disorder. 1 in 26 people will develop seizure disorder during their lifetime. Seizure is a transient, uncontrolled electrical discharge of neurons in the brain that interrupts normal function. Seizures may accompany a variety of disorders, or they may occur without any apparent cause. Seizures from systemic and metabolic problems are not considered seizure disorder. They stop when the underlying problem is corrected. Metabolic problems that may cause seizures include acidosis, electrolyte imbalances, hypoglycemia, hypoxia, alcohol, barbiturate withdrawal, dehydration, water intoxication. Extracranial disorders that may cause seizures include systemic lupus, diabetes, hypertension, sepsis, and heart, lung, liver, or kidney diseases. Etiology and pathophysiology. Seizure disorder has many possible causes. The most common ones vary by age. Common causes during the first 6 months of life are severe birth injury, congenital defects involving the CNS, infection, and inborn errors of metabolism. In those 2 to 20 years of age, the main causes are birth injury, infection, head trauma, and genetic factors. In young adults 20 to 30 years of age, seizure disorder usually occurs from structural lesions such as trauma, brain tumors, or vascular disease. After 50 years of age, the main causes are stroke and metastatic brain tumors. However, 1/3 of all cases are idiopathic. This means they cannot be attributed to a specific cause. These cases are known as idiopathic generalized epilepsy, IGE. Seizure disorder is characterized by a group of abnormal neurons that seem to fire without a clear cause. Any stimulus that causes a neuron's cell membrane to depolarize can cause this firing. It spreads by physiologic pathways to involve near or distant areas of the brain. Localization of the seizure focus, place where the seizure originates, is critical to the success of any possible surgical treatment. Besides neuron alterations, changes in the function of astrocytes may play several key roles in the recurring seizures. Activation of astrocytes by hyperactive neurons is one of the crucial factors that causes nearby neurons to generate an epileptic discharge. We continue to learn about abnormal neural antibodies that can cause seizures. N-methyl diaspartate NMDA receptor antibodies are present in the CSF in 80% of patients. The emerging concept of autoimmune seizure disorder may lead to better outcomes for those resistant to drug therapy. Genetic link. Genetic abnormalities may be an important factor contributing to IgE. The role of genetics in seizure disorder is complex because it is hard to separate genetic from environmental or acquired influences. In some types, families carry a predisposition to seizure disorder. There are naturally lower thresholds of stimuli such as trauma, disease, and high fever. Other types of IgE are related to changes in specific genes that control the flow of ions in and out of cells, regulate neuron signaling, or are involved with protein and carbohydrate metabolism. Sometimes seizure disorder is related to a specific genetic disorder that affects various parts of the body and causes seizures. Many cause brain abnormalities or metabolic disorders, e.g. phenylketonuria, PKU, and have seizures as a major feature. Other seizures are known to have a genetic basis, but we have not found the gene that causes them. Clinical manifestations. Specific manifestations of seizure are determined by the site of the electrical disturbance. The preferred way of classifying seizures is based on the clinical and EEG manifestations. This system divides seizures into three major classes: generalized onset, focal onset, and unknown onset. They are further described under each classification as motor or non-motor. Descriptors address what occurs during the seizure. Depending on the type, a seizure may occur in four phases. 1. Prodromal phase, with sensations or behavior changes that precede a seizure by hours or days. 2. Aural phase, the sensory warning that is similar each time a seizure occurs and is considered part of the seizure. 3. Ictal phase, from first symptoms to the end of seizure activity. And 4. Postictal phase, the recovery period after the seizure. Generalized onset seizures. Generalized onset seizures start over wide areas of both sides of the brain. They are characterized by bilateral, synchronous epileptic discharges from the onset of the seizure. In most cases, the patient has impaired awareness for a few seconds to several minutes. Tonic-clonic seizure. Tonic-clonic seizure, formerly called grand mal, is the most common generalized onset motor seizure. During a TC seizure, the patient loses consciousness and falls to the ground if upright. The body stiffens, tonic phase, for 10 to 20 seconds, and the extremities jerk, clonic phase, for another 30 to 40 seconds. Cyanosis, excessive salivation, tongue or cheek biting, and incontinence may occur during the seizure. In the postictal phase, the patient usually has muscle soreness, feels tired, and may sleep for several hours. Some patients may not feel normal for several hours or days after a seizure. The patient has no memory of the seizure. Other generalized onset motor seizures. Other types of generalized onset motor seizures include tonic and clonic. The tonic seizure involves a sudden onset of increased tone in the extensor muscles, contributing to sudden stiff movements. Tonic seizures most often occur in sleep and affect both sides of the body. Patients will fall if they are standing when the seizure occurs. Tonic seizures usually last less than 20 seconds. The patient usually stays awake. Clonic seizures begin with loss of awareness and sudden loss of muscle tone, followed by rhythmic limb jerking and may or may not be symmetric. Clonic seizures are rare. Generalized atonic seizure or drop attack involves either a tonic episode or a paroxysmal loss of muscle tone. Begins suddenly with the person falling to the ground. Seizures typically last less than 15 seconds. The person usually stays conscious and can resume normal activity immediately. Patients with atonic seizure are at great risk for head injury. They often have to wear protective helmets. Generalized onset non-motor absence seizures. Absence seizures usually occurs only in children and rarely beyond adolescence. This type of seizure may stop altogether as the child matures, or it may evolve into another type of seizure. A typical absence seizure is marked by a brief staring spell that resembles daydreaming. It often goes unnoticed because it lasts less than 10 seconds. Usually the patient is unresponsive when spoken to during the seizure. The EEG has a classic spike wave pattern with 3 per second. In atypical absence seizure, staring spell is accompanied by other signs and symptoms such as eye blinking or jerking movements of the lips. This type of seizure often lasts more than 10 seconds, as much as 30 seconds, with a gradual beginning and end. If the patient has existing cognitive impairment, it may be hard to tell seizure activity from usual behavior. Atypical absence seizures usually come into adulthood. An EEG shows typical spike and wave patterns with fewer than 3 per second. Other generalized onset non-motor seizures include myoclonic and eyelid myoclonia. The myoclonic absence seizure is characterized by rhythmic arm abduction, 3 movements per second, leading to progressive arm elevation. Usually lasts 10 to 60 seconds. Eyelid myoclonia refers to jerking of the eyelids at least 3 per second, often with upward eye deviation. Usually lasts less than 10 seconds. Focal onset seizures. Focal onset seizures, formerly called partial or partial focal seizures, are the other major class of seizures. Focal seizures begin in one hemisphere of the brain in a specific region of the cortex as shown by the EEG. They cause sensory, motor, cognitive, or emotional manifestations based on the function of the involved area of the brain. For example, the discharging focus is in the medial aspect of the postcentral gyrus. Patient may have paresthesia in the leg on the side opposite the focus. This can help distinguish the type of seizure event. Focal onset seizures may be described by level of awareness, aware or impaired awareness. However, this is optional and applied only when awareness is known. Focal awareness seizures are called simple partial seizures. Patients are conscious and alert, but have unusual feelings or sensations that can take many forms. They may have sudden and unexplainable feelings of joy, anger, sadness, or nausea. They may hear, smell, taste, see, or feel things that are not real. In a focal impaired awareness seizure, previously called complex partial seizures, patients have a loss of consciousness or a change in their awareness, producing a dreamlike state. Their eyes are open. They make movements that may seem purposeful, but they cannot interact with observers. During a seizure, some people may do things that can be dangerous or embarrassing, such as walking into traffic or removing their clothes. May continue an activity started before the seizure, such as counting coins or choosing items from a grocery shelf. After the seizure, they do not remember the activity performed during the seizure. Seizures usually last 1 to 2 minutes. Patients may be tired or confused after the seizure, may not return to normal activity for hours. The degree of awareness can be unspecified and the seizure classified as motor or non-motor. Motor activities include atonic, loss of tone, tonic, sustained stiffening, clonic, rhythmic jerking, myoclonic, irregular brief jerking, or epileptic spasms, flexion or extension of arms with flexion of trunk. Some people show strange behavior such as lip smacking or other repetitive purposeless actions, automatisms. The focal non-motor seizure, patient can have emotional manifestations such as fear or joy, strange feelings or symptoms such as racing heart, goosebumps, or waves of heat or cold. Psychogenic non-epileptic seizures, PNES. Because of the close resemblance, psychogenic seizures may be misdiagnosed as seizure disorder. Proper diagnosis usually requires video (EEG) monitoring to identify associated events. The diagnosis of seizure disorder is excluded. History of emotional or physical abuse or a specific traumatic event often emerges. Some patients may have both psychogenic seizures and seizure disorder. Care provided by a specialist is essential. Once the diagnosis is made, treatment of choice is psychological intervention. Complications: physical. Status epilepticus is a state of continuous seizure activity or a condition in which seizures recur in rapid succession without return to consciousness between seizures. SE is defined as any seizure lasting longer than 5 minutes. The longer a seizure lasts, the less likely it is to stop without drug therapy. SE is a neurologic emergency that can occur with any type of seizure. The highest incidence occurs in children and older adults. During repeated seizures, the brain uses more energy that can be supplied. As neurons become exhausted and cease to function, permanent brain damage may result. Convulsive status epilepticus (CSE) is the most common form. It occurs with prolonged or repeated tonic-clonic seizures. The goal of therapy is to rapidly end clinical and electrical seizure activity. Without effective timely treatment, CSE can lead to fatal respiratory insufficiency, hypoxemia, dysrhythmias, hyperthermia, and systemic acidosis. Prognosis for CSE is related to its duration and the patient's age. The term non-convulsive status epilepticus is used to describe long or repeated focal impaired awareness seizures. Symptoms may be subtle, making it hard to tell recovery from seizure symptoms. No consistent time frame dictates when the state is considered an emergency. Depends on the length and frequency of seizure activity. Refractory status epilepticus is continuous seizure activity despite administration of first and second line therapy. RSE carries a high risk for mortality and neurologic damage. This highlights the need for careful, rapid escalation of treatment for CSE to avoid progression. Super refractory SE is a refractory condition that continues or recurs 24 hours or more after starting anesthetic treatment. It also includes cases in which seizure activity returns after withdrawal or anesthetic drugs or persists after 7 days of continuous general anesthesia. About 15% of patients who enter the hospital with SE become super refractory. Subclinical seizures are a form of SE in which a sedated patient seizes but there are no external signs because of sedative use. For example, a patient under sedation for ventilatory support in the ICU could have a seizure without physical movement, and we miss the seizure occurrence. People with seizure disorder have a higher mortality rate than the general population. Severe injury and even death can result from trauma suffered during a seizure. Patients who lose consciousness during a seizure are at greatest risk. Other deaths are due to accidents during seizures, suicide, treatment-related death, death from an underlying disease, or sudden, unexpected death in epilepsy, SUDEP. SUDEP affects about 1 in 150 persons with uncontrolled seizures each year. It is almost always associated with tonic-clonic seizures. Occurrence is higher in males, persons taking multiple anti-seizure drugs, and patients with poorly managed seizure activity. The exact cause is not known. It could be related to respiratory dysfunction, dysrhythmias, or cerebral depression. Specific teaching about medication adherence and disease awareness is critical for at-risk people. Psychosocial. Perhaps the most common complication of seizure disorder is the effect on a patient's lifestyle. A patient may have ineffective coping methods because of psychosocial problems related to having seizure disorder. An increased incidence of depression occurs in people who have seizures that are difficult to control. Many anti-seizure drugs have side effects that overlap with depressive symptoms. Although attitudes have improved in recent years, a diagnosis of seizure disorder still carries a social stigma. Patients may be victims of discrimination in employment and educational opportunities. Transportation may be difficult if state law does not allow the person to drive. Screen patients often for depression. Encourage them to pursue available treatment options. Diagnostic studies. A diagnosis of seizure disorder may have many socioeconomic, physical, and psychological consequences for the patient. Accurate diagnosis is crucial. The most useful diagnostic tool is an accurate, comprehensive description of seizures and the patient's health history. Information from caregivers can be helpful. The EEG is useful, but only if it shows abnormalities. Abnormal findings help determine the type of seizure and pinpoint the seizure focus. Ideally, an EEG should be done within 24 hours of a suspected seizure. However, only a small number of patients with seizure disorder have abnormal EEG findings the first time the test is done. Repeated EEGs or continuous EEG monitoring may be needed to detect abnormalities. EEG is not a definitive test because some patients without seizure disorder have abnormal patterns on their EEGs. Many patients with seizure disorder have normal EEG results between seizures. If abnormal discharges do not occur during the 30 to 40 minutes of sampling during an EEG, tests may not show an abnormality. Magnetoencephalography may be done with the EEG. This test has greater sensitivity in detecting small magnetic fields of neuron activity. A CBC, serum chemistries, studies of liver and kidney function and urinalysis should be done to rule out metabolic disorders. A CT scan or MRI should be done in any new onset seizure to rule out a structural lesion. cerebral angiography, single photon emission computed tomography SPECT, magnetic resonance spectroscopy MRS, MRA, and positron emission tomography PET may be done in certain situations. If an MRI shows a spot or lesion but EEG results differ, MEG can determine if the brain waves are coming from the lesion. MEG can be helpful in a patient with prior brain surgery, as EEG results may be affected by changes in the scalp and brain. The International League Against Epilepsy has developed specific diagnostic criteria for each type of seizure, including conditions that resolve over time. If a patient is diagnosed with seizure disorder, the seizure type must be correctly identified to determine the appropriate treatment. Interprofessional care. Most seizures do not require emergency medical care because they are self-limiting and rarely cause bodily injury. However, if SE or significant bodily harm occurs, or if the event is a first-time seizure, medical care should be sought immediately. Table 58.6 outlines the diagnostic studies. Table 58.7 summarizes emergency care. Drug therapy. The main treatment for seizure disorder is anti-seizure drugs. Because a cure is not possible, the goal of therapy is to prevent seizures with minimal drug side effects. Drugs generally stabilize nerve cell membranes and prevent spread of the epileptic discharge. Therapy should begin with a single drug based on the patient's age and weight and type, frequency, and cause of seizure. Dosage should be increased until seizures are under control or toxic side effects occur. Anti-seizure drugs successfully control seizures for about 70% of patients. Seizure control is not achieved with a single drug. Dosage or timing of administration may be changed or a second drug may be added. About one-third of patients need a combination regimen for enough control. Patients should discuss new treatment with their HCPs to provide the best control with the least amount of medication. The therapeutic range for each drug is the serum level above which most patients have toxic side effects and below which most continue to have seizures. Therapeutic drug ranges are only guides for therapy. The patient's seizures are well controlled with a subtherapeutic level. Drug dosage does not have to be increased. Likewise, if a drug level is above the therapeutic range and the patient has good seizure control without toxic side effects, drug dosage does not have to be decreased. Serum drug levels are monitored if seizures continue to occur, frequency increases, or drug adherence is questioned. Because they have large therapeutic range, many newer drugs do not require drug level monitoring. The main drugs to treat tonic-clonic and focal onset seizures are phenytoin dilantin, carbamazepine tegretol, phenobarbital, and divalproex. The drug used most often to treat generalized onset non-motor and myoclonic seizures include ethosuximide, Zarantin, divalproex, and clonazepam clonopin. Some drugs are effective for multiple seizure types. Pregabalin, Lyrica, is used as an additional treatment for focal aware or impaired awareness seizures not successfully controlled with one medication. Treatment of SE requires a rapid-acting IV anti-seizure drug. The drugs most often used are lorazepam Ativan and diazepam Valium. Because these are short-acting drugs, their administration is followed with long-acting drugs such as phenytoin or phenobarbital. Because of many anti-seizure drugs, e.g. phenytoin, phenobarbital, ethosuximide, lamotrigine, topiramate, have a long half-life. It can be given once or twice a day. This simplifies the drug plan and increases the patient's adherence because the drug does not have to be taken at work or school. Unnecessary combination therapy is avoided whenever possible. Medication should be reviewed routinely and the least effective medication discontinued by tapering. Side effects of anti-seizure drugs involving the CNS include diplopia, drowsiness, ataxia, and mental slowness. Neurologic assessment for dose-related toxicity involves testing the eyes for nystagmus and evaluating hand and gait coordination, cognitive function, and general alertness. As a nurse, you need to be knowledgeable about drug side effects so you can teach patients and start proper treatment. For example, common side effects of phenytoin are gingival hyperplasia, excess growth of gingival tissue, and hirsutism, especially in young adults. Good dental hygiene, including regular toothbrushing and flossing, can decrease gingival hyperplasia. Gingival hyperplasia is extensive. The hyperplastic tissue may be surgically removed, gingivectomy. Phenytoin replaced with another anti-seizure drug. Medication non-adherence can be a problem in people with seizure disorder, often due to undesirable side effects. Take measures to increase adherence to the prescribed drug plan. If HCPs are aware of non-adherence, they can work with the patient in finding an acceptable drug plan. For example, using pregabalin as an adjunct medication in some cases may allow a decreased dose of the primary anti-seizure drug and thus decrease side effects. Gerontologic considerations, drug therapy for seizure disorder. Many older adults have a first single seizure, then do not have another seizure. To be considered for anti-seizure drug therapy, older adults should have recurrent seizures, an obvious structural predisposition for seizures, or onset of seizure disorder presenting as a SE. Older adults are more responsive to anti-seizure drugs than younger adults, but they also are more likely to have side effects at lower serum drug concentrations. Age-related changes in liver enzymes decrease the liver's ability to metabolize drugs. Because the liver metabolizes phenytoin, it should not be used in older patients with liver problems. Potential effects on cognitive function make phenobarbital, carbamazepine, and primidone less desirable for older adults. Carbamazepine, phenytoin, phenobarbital, or primidone can increase the risk for osteomalacia, osteopenia, and osteoporosis. Several newer anti-seizure drugs offer greater treatment benefit to older adults. Compare with older drugs gabapentin, lamotrigine, oxcarbazepine, trileptal, and levetiracetam may be safer. Have fewer effects on cognitive functions and have fewer interactions with other drugs. Surgical therapy. Despite availability of newer drugs with fewer side effects, no solution has been found for medically refractory epilepsy not responsive to drug therapy. About 30% of patients do not respond to anti-seizure drugs. For people with a defined site of seizure origin, epileptogenic zone, research shows the benefit of surgical resection of that focal area over continued use of different anti-seizure drugs. About 80% are seizure-free 5 years after surgery, with 72% still seizure-free at 10 years. Not all patients benefit from surgery, and extensive preoperative evaluation is important, including continuous EEG monitoring and other tests to ensure precise localization of the focal point. Surgical candidates must meet three requirements: 1. Confirmed diagnosis of seizure disorder; 2. Inadequate trial with drug therapy without satisfactory results; and 3. Defined electroclinical syndrome type of seizure disorder. Other therapies: vagal nerve stimulation, VNS, a form of neuromodulation. It's used as an adjunct to drugs when an accessible focal point cannot be identified for surgical removal. See, the exact mechanism of action is unknown. May increase blood flow to specific brain areas, could raise levels of neurotransmitters important to seizure control, and change EEG patterns during a seizure. In VNS, surgically implanted electrode in the neck is programmed to deliver electrical impulses to the vagus nerve, usually on the left side. The patient activates the electrode with a magnet when they sense a seizure is imminent. Newer devices respond to an increasing heart rate, which is often associated with seizures. Adverse effects include coughing, hoarseness, dyspnea, and tingling in the neck. Battery life is 5 to 10 years, and surgical replacement is needed. Benefits of VNS can be seen within 24 months after implantation. Contraindications include a history of dysrhythmias or sleep apnea. Responsive neurostimulation, NeuroPace RNS system, similar to a cardiac pacemaker, continuously monitors the EEG to detect abnormalities in response to seizure activity by delivering electrical stimulation to a precise location. The device is placed under the skin outside the skull with connections to electrodes over the area of seizure focus. The HCP uses a programmable wand to download information about seizure activity. This is used to assess treatment efficacy and guide care. This modality is an option for persons who are not surgical candidates or have multiple areas of seizure focus. A ketogenic diet is a special high-fat, low-carbohydrate diet that helps control seizures in some people. A person on this diet produces ketones that pass into the brain, where they replace glucose as an energy source. Meals are carefully planned to restrict the amount of protein and carbohydrates in the diet. Patients on this diet who use anticoagulants need close monitoring for bleeding. Although HCPs are more likely to recommend a diet for children and adults, the diet can work equally well in both age groups. Most people must continue their use of anti-seizure medication, but may take smaller doses or fewer medications. Seizures may worsen if the diet is stopped abruptly. Long-term effects of the diet are not clear. Biofeedback to control seizures is aimed at teaching the patient to maintain a certain brainwave frequency that is refractory to seizure activity. Further trials are needed to assess the effectiveness of biofeedback for seizure control. Nursing management, seizure disorder, nursing assessment. Obtain data related to a specific seizure episode from a witness. Nursing diagnoses. Impaired breathing, difficulty coping, risk for fall-related injury. Planning. The overall goals are that the patient with seizure disorder will be free of injury during a seizure, have optimal mental and physical functioning while taking anti-seizure drugs, and have satisfactory psychosocial functioning. Nursing implementation. Health promotion. Following general safety measures, e.g. wearing helmets in situations involving risk for head injury, can prevent some seizure disorders. Improved perinatal care has reduced fetal trauma and hypoxia and thus brain damage leading to seizure disorder. Patient with seizure disorder should practice good general health habits, maintain proper diet, get adequate rest and exercise, help the patient identify events or situations that cause seizures and provide suggestions for avoiding them or handling them better. Teach the patient to avoid excess alcohol use, fatigue, and loss of sleep. Help the patient handle stress constructively. Acute care. Nursing care for a hospitalized patient with seizure disorder or a patient who has had seizures due to other factors involves observation and treatment of the seizure, patient and caregiver teaching, and psychosocial intervention. When a seizure occurs, carefully observe and record details of the event because the diagnosis and subsequent treatment often rest on the seizure description. What events preceded the seizure? When did the seizure occur? How long did each phase, oral, if any, ictal, post-ictal, last? What occurred during each phase? All subjective data, usually the only type of data in the oral phase, and objective data are important. Note the exact onset of the seizure, which body part was affected first and how. Course and nature of the seizure activity, loss of consciousness, tongue biting, automatisms, stiffening, jerking, total lack of muscle tone. Body parts involved and their sequence of involvement, and autonomic signs such as dilated pupils, excessive salivation, altered breathing, cyanosis, flushing, diaphoresis, and incontinence. Assessment of the postictal period should include a detailed description of the level of consciousness, vital signs, pupil size, position of the eyes, memory loss, muscle soreness, speech disorders, aphasia, dysarthria, weakness or paralysis, sleep period, and duration of each sign or symptom. After the seizure, the patient may need repositioning to open and maintain the airway, suctioning, and O2. Seizure can be frightening for the patient and others who witnessed it. Assess their level of understanding and provide information about how and why the event occurred. It's an excellent chance for you to dismiss many common misconceptions about seizures. Ambulatory care. Prevention of recurring seizures is the major goal of treatment. Help the patient understand that for treatment to be effective, drugs must be taken regularly and consistently. Review details of the drug plan and what to do if the dose is missed. Usually the dose is made up. The omission is remembered within 24 hours. Caution the patient not to adjust drug dosages without HCP guidance because this can increase seizure frequency and cause SE. Encourage the patient to report any medication side effects and keep regular appointment with the HCP. You have a vital role in teaching the patient and caregiver. Review the guidelines for teaching shown in Table 5810. Teach caregivers in emergency management of tonic-clonic seizures. Remind them it is not necessary to call an ambulance or send a person to the hospital after a single seizure unless the seizure is prolonged. Another seizure immediately follows, extensive injury has occurred, or it is unknown if this was a first-time seizure. Patients with seizure disorder may have concerns or fear related to recurrent seizures, incontinence, or loss of self-control. Support patients through teaching and by helping them use effective coping mechanisms. Perhaps the greatest challenge for a patient with seizure disorder is adjusting to the limitations imposed by the illness. Discrimination in employment is a serious problem facing the person with seizure disorder. For issues relating to job discrimination, refer patients to the State Department of Vocational Rehabilitation or the U.S. Equal Employment Opportunity Commission. Help the patient find appropriate resources. If you think associating with others who have seizure disorder would be beneficial, refer the patient to the local chapter of Epilepsy Foundation. This volunteer agency offers varied services to patients with seizure disorders. Refer the patient who is an eligible veteran to a Department of Veterans Affairs medical center that provides comprehensive care. If intensive psychological counseling is needed, Refer the patient to a community mental health center. Social workers and welfare agencies can help with financial implications and living arrangements. State agencies specializing in vocational rehabilitation services can provide vocational assessment, counseling, and funding for training. They can help with job placement for patients whose seizures are not well controlled. They offer financial assistance for transportation and medical costs related to vocational rehabilitation and job maintenance. Driving laws for patients who have seizure vary from state to state. For example, some states require a 3-month seizure-free period before issuing or reissuing a driver's license. Others require up to a year. The EF provides current information on driving laws for each state. Tell the patient that medical alert bracelets, necklaces, and identification cards are available through the EF, local pharmacies, or companies specializing in identification devices. Using medical identification is optional. Some patients have found that beneficial, but others do not want to be identified as having seizure disorder. Encourage the patient to learn more about seizures through self-education. The EF provides information in old pamphlets, has an extensive website, and may offer support groups. Many agencies that offer services to patients with seizure disorder offer teaching aids and support. Evaluation, expected outcomes, have a breathing pattern adequate to meet O2 needs, have no seizure-related injury, express acceptance of seizure disorder by adhering to treatment plan.